We do have another wonderful speaker who you can see right here. This is Dr. Jadira Del Rivero, and Dr. Del Rivero is with the NIH. Her specialties are medical oncology and endocrinology, and she's going to speak with us today about clinical trials for NETs from the perspective of a multidisciplinary NET treatment program. So, welcome, Dr. Del Rivero.
Oh, thank you so much for the invitation. I hope you can all hear me. Okay, great. So, hi, good afternoon, everyone, and morning for some of us. It is a pleasure to be here today with you all. And what I'm going to discuss today is about the different clinical trials in neuroendocrine tumors. And something that I'm going to discuss today as well is about the active clinical trials available for you all in the whole United States. So in terms of therapies of advanced neuroendocrine tumors, as Dr. Mohammed has discussed earlier today, there has been a lot of advancement. It's a very exciting time in the management as well as the understanding of these neuroendocrine tumors. And as you can see here, there has been quite a few agents approved for the treatment of advanced neuroendocrine tumors. However, we still wanted to develop more treatment. We still wanted to understand more about the biology of these tumors to then develop more effective therapies. We still wanted to be able to shrink those tumors. So, and that's where the clinical trials, plays a role. It's an important role in order to develop more effective therapies. So, what are clinical trials? So clinical trials are research studies that test how well new medical approaches works in people. It could be a new medicine. It could be what we call behavioral tool. It could be screening modalities. So we wanted to understand how specific research studies is of benefit to patients. So each study is trying to find better ways to prevent, also screen, diagnose, and as well as to treat disease. And that's why clinical trials are so important. Clinical trials also help us to compare new treatments with treatments that are already available. In this case, we know that our treatments available for neuroendocrine tumors that are already approved by the FDA, but then we wanted to also develop a trial to compare new treatment and see what is the difference in terms of efficacy with other treatments that are already approved or available. And the goal of clinical trials is to determine if these treatments, behaviors, or preventions are safe and effective. So in terms of clinical trials, so there are in different phases. So to answer specific questions, we have different phases for these clinical trials. And then we go over some of the examples as I discuss this subject. But phase one, what is a phase one clinical trial? So the phase one clinical trials is when a researcher tests a drug or a treatment in a small group of people for the first time. And it's a first-in-human clinical trial. And the purpose of the phase one study is to understand if the drug or treatment, if it's safe, if there is any side effects associated with that treatment, and that's the phase one study. So what is a phase two study? Is when the new drug or treatment is given to a larger group of people, and that's to also determine its effectiveness as well as to further assess the safety. What is a phase 3 study? The phase 3 study is when the drug is given to a much larger group of people, as we can see here in the slides, a much larger group of people to confirm its effectiveness as well as to monitor side effects and also compare with the standard treatment options as well. And that's going to also help us answer some of the questions that the researchers also have. And the phase 4 clinical trials, after the drug is approved by the FDA and is available to the public, then researchers track over time the safety in the general population, and then we also acquire more information about this. So now let me give you a few examples about the phase 1 study in neuroendocrine tumors. And again, something that I wanted to mention as well is that those are studies that are active and that you also can have availability to the studies. And I went just as a reminder, what's a phase 2 study? The phase 2 study is to determine what is the safe dose. And I wanted to mention this study by Dr. Chauhan. He's the national PI of this study, and we're very fortunate that Dr. Chauhan is here with us. And if you have any questions about his studies, he will be happy to answer any of the questions. But he has a phase 2 study for neuroendocrine tumors, and what he's doing, he's combining a treatment which is called triapine in combination with Luthothera for well-differentiated neuroendocrine tumors. So, and then he has this rationale that by using triapine can enhance activity of Luthothera. So we know Luthothera is already approved by the FDA, as Dr. Muhammad discussed earlier with you. But we know that Luthothera is also effective, but we wanted to potentiate the effect. We wanted to be able to shrink the tumors even more. And that's why Dr. Chauhan is working really hard to then develop combination therapies to make these treatments more effective. And that's why he has this treatment with triapine to enhance the efficacy of Luthothera. But it's a first-in-human study. So and one thing is that in order to develop this phase 1 study, he also developed animal studies. So we also needed to know what is the safety in animals in order to then take it to the clinic and take it to patients. And he already developed the studies in order to develop this trial. And he wanted to, since it's first in human, he first need to establish what is this safe dose in combination with triapine. And he has different dose escalations, meaning that he's increasing the dose in order to determine what is a safe dose. And we're excited about this trial of Dr. Chauhan, and I'm sure that he will be happy to discuss more about this in our Q&A session. So earlier today, Dr. Muhammad also explained to you about the difference of neuroendocrine tumors. We know that there are different types of neuroendocrine tumors, from the well-differentiated neuroendocrine tumors to poorly differentiated or neuroendocrine carcinoma. And I think we are now enhancing the awareness of these poorly differentiated neuroendocrine carcinomas that are more aggressive, that are more rapidly growing tumors. And I think there is also an interest on the net researchers to develop more therapies for these patients. And I wanted to mention that Dr. Satya Das, who is at Vanderbilt, has a study that he's actively accruing for patients with small cell lung cancer, which is a neuroendocrine tumor of the lung, more aggressive, and also including patients with poorly differentiated neuroendocrine carcinomas, we can see here. And his trial is a combining treatment, because these patients that are more aggressive, that are more rapidly growing, they need something that can act quick, chemotherapy-based treatments. And he's combining an agent, which basically is going to help to enhance the efficacy of the chemotherapy. We know that chemotherapy, what is the job of the function of the chemotherapy, is that in the tumor cell is that it disturbs the DNA of the tumor cells. And what happens when there is any abnormalities on the DNA of the tumor cells is trying to repair itself. That's how the body is trying to react. So I'm giving you something that is basically breaking DNAs. And by doing that, the body is trying to repair itself. And now he's trying to use a combination treatment in order to make that more efficacious. It's also a phase 1 study. It's again first in humans. He's going to determine what is the safe dose in order to then move it to a phase 2 study. So now let's discuss about the phase 2 study. As I discussed earlier, the phase 2 study is when the drug is given to a larger group of people, and we're trying to determine how efficacious it is, the treatment. And then we have phase 2 studies available for clinical trial. And again, I wanted to mention again Dr. Chauhan's studies. So Dr. Chauhan, he's working very hard to develop more therapies for neuroendocrine tumors. And again, I wanted to mention that we're very lucky to have him here today. But he's also have a trial of combination telotrestat with Luthothera. And telotrestat is approved for patients that have carcinoid syndromes. And he also has discussed that telotrestat can have an anti-tumor activity. And by combining with the chemotherapy with Luthothera, his question is, like, could we make this treatment more effective? And he has 2 different doses of this study, and it's a randomized study, and he wanted to determine what is the difference between the 2 doses. And my understanding is that this is also accruing patients as well, and is active as well. So now let's discuss about other treatments. Are there other treatments in the setting of clinical trials for neuroendocrine tumors? And they are. Dr. Kim Perez from Dana-Farber, he has treatment with immunotherapy. So we know now, I'm sure one of the questions is, like, what do we know about immunotherapy for neuroendocrine tumors? In immunotherapy, we know that it works with cancer, but when it works well. But now what the science and the researchers is trying to do is trying to understand more about the efficacy of immunotherapy to make it more efficacious for all tumor types. And that's something that the researchers are working, how we can make immunotherapy more effective, how we can achieve the response that we have seen in other tumor types. And I think that's where they're coming with combination chemotherapy, so immunotherapy for the different type of tumors. And at the same time, there are ongoing clinical trials with immunotherapy for neuroendocrine tumors. And Dr. Kim Perez have study of cabozantinib. So Dr. Mohammed explained earlier that there are treatments that affect the blood vessels of the tumor. And that's what we have. Cabozantinib is one of them. It affects the blood vessels in the tumor. And what happens is that with the cancer cells, sometimes that can also suppress the immune system as well, that by giving certain treatments, it can stimulate more the immune system to also make immunotherapy more effective. And that's one of the rationale of giving cabozantinib, which is a treatment that blood vessels in combination with nivolumab. Another interesting part about the study of Dr. Perez that is also actively accruing patients is that this study includes all neuroendocrine tumors except pancreatic neuroendocrine tumors. She's including patients that have lung neuroendocrine tumors. She's including patients that have any other part of the body neuroendocrine tumors except the pancreatic neuroendocrine tumors. Dr. Jonathan Strathberg, I'm sure some of you know Dr. Strathberg, who is known for leading the treatments in the approval of the Luthothera. He also have a clinical trial of the same agent, of the same family, similarly to cabozantinib, the ones that block the blood vessels. He also have another trial using lenvatinib, which is the same. It blocks the blood vessels. And he's also using it in combination with immunotherapy, and that's also for well-differentiated neuroendocrine tumors. And also he's trying to understand if by giving the two together, can we make the therapy more efficacious? Because what we know for neuroendocrine tumors, single-agent immunotherapy doesn't seem to have much activity. And now the question is, if we combine it, can we make it more effective? And I think that's the ongoing questions, and hopefully these clinical trials will help us answer these questions. And then also Dr. Jonathan Strathberg has another active clinical trial of tamoxifen. So what is tamoxifen? So tamoxifen is used for breast cancer. It basically blocks the breast cancer has estrogen receptors and basically blocks the estrogen receptors, because we know that by having these receptors, it makes the tumor more active. So just to simplify the rationale. And Dr. Strathberg has described, and there has been publications, that neuroendocrine tumors also have these estrogen receptors on the surface of the cell. And what we know is that happens is that usually the pathologist look under the has a specific procedures to stain the tumor to see if they have estrogen receptors, and that's something that needs to be an inclusion criteria. So patients that are included in this study needs to have the estrogen receptor positive. And he wanted to know if by using this tamoxifen in neuroendocrine tumors that have expression of the estrogen and progesterone receptors, could he achieve disease control? With this treatment, we can stabilize the growth of the tumor? So that's one of the questions that he would like to answer, and that's also active for recruitment. And then I think one of the discussions, and something that I'm sure you have heard, and even if not in this talk, on different talks, is about liver-directed therapy. So the type of interventional radiology type of treatments for the liver, either liver ablation, liver embolization. And Dr. Sulen, who is a PAN, he has a clinical trial which want to determine what is the benefit of these treatments on patients that have mainly liver dominant disease. And we discussed that a lot of these neuroendocrine tumors may only have liver dominant disease as the only size of disease. And Dr. Sulen has this trial which wanted to see what is the difference and what could be more beneficial of giving either a type of blood embolization, meaning that there is no chemotherapy or any other agent on the type of therapy, or if there is any chemoembolization, meaning that is adding chemotherapy to the procedure, or if there is any drug-eluting beads, which is basically a type of beads, radiated beads that is also given, and if that could also he wanted to compare between the three groups and determine which one is more efficacious, which one may be better, which one has less side effects. And I think that's something that he studied. And those are for patients that have liver dominant disease and they're still active and is still seeing patients as well. And then I wanted to discuss this study because we discussed about immunotherapy for the well-differentiated neuroendocrine tumors. And I also wanted to discuss it for the poorly differentiated. We discussed there is a phase 1 study that is for poorly differentiated neuroendocrine carcinoma, and there is also an immunotherapy combination treatment as well for poorly differentiated neuroendocrine carcinoma. Dr. Tesfaye is a PI, is a multi-center study, something that I did not mention earlier. A lot of these studies, there are multiple sites as well. Dr. Shohans is the national PI, that meaning a few of his studies that are in multiple sites throughout the country. So Dr. Tesfaye has this study as well that are available in different institutions throughout the country, and this is also the combination immunotherapy for poorly differentiated neuroendocrine tumors. And he used the combination of cabozantinib that Dr. Muhammad explained as the one that blocks the blood vessel growth and block the blood vessels within the tumor in combination with immunotherapy. And he wanted to understand, and his question is, by giving this combination, can I shrink the tumors in this type of neuroendocrine tumors? So they're still active and it's occurring as well. So now we discussed what is a phase 2 study. So we know that the phase 2 study, we proved that in the phase 2 study that the treatment that was studying is efficacious. Now, on the phase 3 study, the treatment wanted to give it to a more larger group of people, as we discussed earlier. So we really want to confirm, okay, what we saw, the activity, the signal, can we confirm it? Can we really determine if this is effective? And also monitor side effects as well, and sometimes compare it with other treatments that are available as well. So in that, there's a few trials that are available for neuroendocrine tumors that are actively accruing. So there is this, the Luthothera Trial, and that's a randomized study. So patients, they're either randomized, meaning that when they do the eligibility and determine if the patient is eligible to be enrolled, then decide which group the patients will go, and then decide is Luthothera versus everolimus. So it's either some patients will go to Luthothera and some patients will receive everolimus. Everolimus is considered the standard of care for neuroendocrine tumors. And the question that I would like to answer is how, if this is beneficial, can by giving this treatment, can that slow down the progression of the disease growth or the tumor growth? It's a multi-center international study. There are 9 centers available here in the United States. So there are also centers in Europe as well that they have this treatment available. And there is also another phase 3 study, which is for higher grade neuroendocrine tumors. So earlier, they discussed about the well-differentiated neuroendocrine tumors versus the poorly differentiated neuroendocrine tumors. But on the well-differentiated neuroendocrine tumors, we have different grades. We have grade 1, and that's based on the Ki-67 as well. So the Ki-67, just as a reminder, is a proliferation index, how the cells are able to divide and proliferate. And for well-differentiated, usually Ki-67 is less than 3%. And on the original study that you heard earlier with the NETHER-1, with the Luthothera, the patients that were included were well-differentiated neuroendocrine tumors. But now this study focused on higher grade neuroendocrine tumors, grade 2 and grade 3 neuroendocrine tumors. So there is also a multi-center study, and then it's an international study. So there are 2 centers here in the United States that are available as well. And I just wanted to discuss that. And also there is a cabozantinib study. Dr. Jennifer Chant is the PI. It's a multi-center study. There are various sites in the United States. And it's also patients are either randomized to receive treatment versus placebo, so many not treatment. But if they see any disease grows in that group, then where the patients will receive off-label cabozantinib. And that's also for patients that have advanced neuroendocrine tumors that had already progressed in other type of treatments, and that's also available in the many sites in the United States. Now, let's discuss very briefly. I know that I only have a few 10 minutes, but let's just discuss very briefly what do we have available at the NIH, and that's my home institution. So one of the things that we know about the management of neuroendocrine tumors, it could be quite challenging. And the reason why is because even though we have FDA-approved agents, So we still don't know when or what combination therapeutic approach should be used, how long the treatment needs to be continued, what subgroup of patients or a particular treatment option should be used. Can we understand more about the roles of immunotherapy in the higher grade neuroendocrine tumors? And that's why the answer, and one of the things that we have been working here at the NIH to understand more about neuroendocrine tumors, and we know that it's an unmet need, is that by a comprehensive classification system that incorporates tumor clinical state, genomic and epigenetic alteration, as well as gene expression profile that could serve to better define the biology of neuroendocrine tumors and hopefully establish correlations as well with clinical outcomes, and with the hope that we can also develop more effective therapies for these neuroendocrine tumors. So we also understand that families living with neuroendocrine tumors has very unique challenges. Sometimes it takes a long time to diagnosis, and sometimes by the time the patients are diagnosed with neuroendocrine tumors are diagnosed at an advanced stage. Most medical centers have limited experience, and so that's why patients has to search for experts, and they sometimes have to travel outside of the home region, and that can also be a challenge for patients as well. And there is no standardized treatment guidance, and that creates some uncertainties in search for answers. And because of all these challenges, patients sometimes feel isolated. So one of the answers to this is we would like to help to develop an easily and accessible national and international patient engagement network for net research and patient care with advocacy support groups. NCAN is doing a wonderful job in bring awareness, educate patients, and that's what we need to bring together. We need to bring together physicians, scientists, support groups, so that we can help each other and we can search for all of the answers that we ask on a daily basis. So also there are neuroendocrine tumor researchers that also face hurdles as well to develop cures. Sometimes it takes a long time to accrue patients. I discuss all the available trials, and sometimes even on those trials, it's difficult to accrue patients. We need a multidisciplinary patient care need for these patients. It is considered a rare tumor, and sometimes we need a group of neuroendocrine tumors need to be seen in a multidisciplinary approach. Sometimes there are lack of coordination between teams, and sometimes there are limited efficiency as well in regards to clinical trials. And that's something that we're trying to improve as well. One thing that we struggle, and Dr. Shahhan and Dr. Mohammed and everybody today that were speakers as well, they may agree with me that there are limited diversity of neuroendocrine tumor cell lines. So that's a hurdle for us, because without having these cell lines, we cannot take it to the lab and determine if a specific treatment A could be effective, and that's a struggle for us. And also it can be challenges having this rare disease. Sometimes for breast it can be challenges. There is less resources for grant funding as well, and that's something that we, as an institution, we're also trying to understand more about that. And we also believe that collaborative, well-funded research network for neuroendocrine tumors could provide development of more therapies and new standard of care for patients in need. So some of the answers, we hope that some of the answers could be addressed by our natural history for tumor for children and adults with neuroendocrine neoplasm. We have an interest also to study children with neuroendocrine tumors. We wanted to study this tumor throughout the whole spectrum from young to adult. We wanted to understand about the biology of disease. We wanted to understand the clinical characteristic of disease, the pattern of disease progression. So we wanted to understand why some tumors respond to treatment and others doesn't. So we hope by gathering all this information in a more prospective manner, more standardized manner, could help us answer some of these questions. So I have to say that I have to thank Dr. Riley and Dr. Whitman, who are the directors of the Rare Tumor Initiative. We worked this in collaboration with the Rare Tumor Initiative at the NCI. We wanted to study these patients longitudinally with obtaining all these informations. We are also obtaining clinical and laboratory evaluations for patients that comes to the NIH, but we also have a cohort of patients that do not come to the NIH that we enroll in remotely, and we're still able to gather all this information. We do a molecular profile in the tumor as well and obtain their DNA for analysis. And the whole goal is to be able to develop more therapies, to be able to understand more what the endpoints are needed for clinical trials, as well as to develop screening guidelines for these tumors. I know I have a warning if I have 5 minutes left, but I'm happy to discuss more in detail in the Q&A session. So this is just an algorithm of how we're able to bring patients to the clinical center. And also patients that are seen here, they can either stay on the natural history study, or we also have clinical trials available at the NIH that they could be eligible for. So one disease I want to discuss today is about pheochromocytomas and paragangliomas. It's also a rare disease, and it's a neuroendocrine tumor. Dr. Carl Sack has the natural history study for pheochromocytomas and paraganglioma, has seen this tumor type for many, many years now, and he has been able to understand more about how these tumors behave and what these tumors are, and understand about more about how can we diagnose these tumors as well. So we do have now a trial. So I am fortunate to be the co-PI with Dr. Perez for patients with pheochromocytomas and paragangliomas. It's using a type of chemotherapy called temozolomide, and we can randomize the patient, meaning one arm will be temozolomide alone, and the other one it will be in combination treatment to understand which one could be more efficacious. And that's this is a study that is activated throughout the whole. It's a national study. It's activated in many different sites in the United States, and it's available to enroll patients with pheochromocytomas and paragangliomas. And then these patients is also neuroendocrine tumors. We discussed earlier that neuroendocrine tumors has somatostatin receptors in the surface of the cells, and pheochromocytoma the same. So they also have somatostatin receptors in the surface of the cells, making a 6-8 gallium dotatate a good tool, a good diagnostic tool, and for pheochromocytomas and paragangliomas. And as you can see here in this picture, you can see other functional imaging modalities, and you can see that the gallium scanner is able to pick up a lot of the lesions more defined compared to other imaging modalities. And because of that, it makes sense, if Luthothera is used for patients that have somatostatin receptor tumor, could we use the same as Luthothera and to determine what is efficacy? And that's why at the NIH we have this trial of Luthothera for patients with pheochromocytomas and paragangliomas. We also have a treatment of Luthothera. We discussed earlier Dr. Shahan's work of combining treatments for neuroendocrine tumors. And this is another trial that we have available at the NIH, is the combination of Luthothera with olaparib. So Dr. Shahan has different treatments that use combination therapy in order to make Luthothera more effective. And that we also have the same question. And we also have in this treatment that is also open for recruitment as well. I'm just going to go a little bit quicker. I'm not running out of time. We also have, but these slides are available to you if you have any questions. And then we also study the higher grade neuroendocrine carcinoma, and I'm working with Dr. Thomas, who's also an oncologist here at the NCI, and we're trying to develop more therapies for neuroendocrine carcinoma, as we can see here. There are one thing that I wanted to mention is how can we get information about these clinical trials, because all of this information is available. You can Google, you can go to clinicaltrials.gov, and that's how you're able to obtain more information about these trials. And this is kind of like a picture of how you can go to clinicaltrials.gov. So you can go to Google, you can type clinicaltrials.gov. Once you go to the website, there is a way that you can type what is the disease, the condition of the disease. You can also type where you are in the country, so that way you can say, well, what are the clinical trials available in my hometown? And that's something that you can know and learn by going to clinicaltrials.gov. And I think those are the questions, some of the questions that I get all the time. What should I ask when if I offer a clinical trial? So what are the questions that I need to ask to the researcher, to the physician? And that's some of the questions that are here. And we can also discuss in the Q&A, but it's one of the things that you need to ask is what is the purpose of the study? What researchers think is the approach may be affected? What are the risks? What are the benefits of having this treatment? What kind of therapies, procedures, or tests I need to do or have during the trial? And how this could then affect my daily life, my quality of life. And as you can see on the bottom, there is a website. You can definitely go there And that way, you need more information about what clinical trials are and what are the questions you need to ask, please go to that website. And those are some of the tips that it's important for you to know about what you need to ask your doctors about the clinical trials. So it's important that whenever you go, you can consider taking a family member or a friend. I know with the COVID pandemic, it's harder to bring a family member, but sometimes now with the Zoom and WebEx, and I think there's ways that you can also communicate with your family. Even if you go and see in person with your doctor, maybe you can have your phone and just FaceTime with your family members, so that way they're always available there in case they have any questions. Plan to ask any question. Don't hesitate to ask any question. Write those questions down. So that way you can remember. Or sometimes it happens, even to me, if I was a doctor, you have all these questions, you don't write those down. And then by the time you go there, it's very difficult to remember all of them. So I think it's important that in any question that you have and you have the answers, write those down. So that way you can always go back and revisit and ask those questions again. So I just wanted to finish to acknowledge everyone that I've been very fortunate here at the NCI and in the whole NIH to work with wonderful physicians who want to make a difference in the treatment of neuroendocrine tumors. I also wanted to give a special thanks to Dr. Shahan, Dr. Strasberg, Dr. Chen, Dr. Perez, Dr. Das, and Dr. Suarez, who helped me to get all the information to you when in the first few slides about the clinical trials available to the NIH. And of course, I want to thank the more importantly is to all of you, the patients, without whom none of the studies will be possible. I usually like to finish with this sentence, individually we are a drop, together we're an ocean. In order to be able to develop more therapies, we need to work together, patients and physicians together. This is important. We can ask questions and then we can develop more effective therapies. And I think that's something that all of us, everybody here today is working hard for. I want to thank you for your attention. Of course, I want to thank NCAN as well. Thank you so much.